This is John Weigeld, your coordinating editor for CSAP 17 Audio Companion. I have asked Dr. Casey Calkins, one of our CSAP 17 authors, to speak with me today. Casey, can you share with our audience where you are located, your primary focus of your clinical practice, and maybe a little bit of how you spend your usual day, if there is one of those?
Sure. So I'm located in Milwaukee, Wisconsin. I'm a professor of surgery with the Department of Surgery at the Medical College of Wisconsin. My primary hospital in which I work is the Children's Hospital of Wisconsin here in Milwaukee. I've been in practice since 2005 after completing my fellowship in Kansas City. I'm a general pediatric and thoracic surgeon, so I do the gamut of general surgery confined to neonates, infants, children, toddlers, young adults, and adolescents. And I do have some areas of focus. I don't think we're going to be talking about any of those today, but it's colorectal disorders of children. But I still do a fair amount of general surgery, which I think we're going to talk about.
I have asked you to share some of your thoughts about various conditions a general surgeon faces when a child walks into his office or he sees them in the hospital. We will be discussing topics from CSAP 17 that are located in the category Problems and Related Specialties. Some of the topics come right from CSAP 17 questions, and others will be from questions that were written by the various committees but were not selected for the final draft of CSAP 17. And I really hope to pick your brain about many of the pediatric surgical topics that general surgeon may find themselves confronted with in their practice. All right, so let's get started. Let me start with, I guess, a common topic, and that would be inguinal hernia. And let's talk about the infant. When we see an infant with an inguinal hernia, is that always a surgical emergency, or how do we manage those?
Inguinal hernias are extraordinarily common. I always tell parents the top one or two operations I do are inguinal hernia repairs in infants and children. It's not necessarily a surgical emergency unless the hernia itself is incarcerated and can't be reduced. But that's fairly rare. So the majority of young children or infants have a reducible component that can be reduced with manual pressure, and elective repair can be scheduled at a time that's convenient for the surgeon and the family. The controversial issue is timing of surgery, specifically as it relates to premature infants specifically. I don't think there's any pediatric surgeon in this country or abroad who would tell you that a inguinal hernia can be observed. These are congenital problems of failure of the patent processus vaginalis to close. Essentially, that's why it's patent. But I think most people would agree that an inguinal hernia ought to be repaired. Again, the issue really of controversy is timing, especially in the premature infant. The operation that's done is the tried and true operation that's been around for decades, and that's ligation of a patent processus, which is the etiology of the problem. Very few infants, toddlers, and children have a direct hernia component like you would see in an adult patient. The other area that's been popularized over the last decade is the laparoscopic repair, and we can talk a little bit about that if you'd like, but suffice it to say that the steps of the operation are the same.
Well, before we get there, in the adult population, we've got this watchful waiting standpoint of inguinal hernia, and you mentioned incarceration. Is incarceration, if you watch these for that period of time when you're waiting, if you will, for the right time to operate on the child, is there a great risk of incarceration?
Right. Yeah, that's a fantastic question, and it's still a question that generates a fair amount of controversy amongst pediatric surgeons because depending on what you read, which is pretty typical in the literature, the incarceration rates can vary. The patients that we get most concerned about in pediatric surgery are the premature infants. And the complicating factors with those children is they oftentimes have comorbid conditions, most specifically related to their respiratory system. But in premature infants, the incarceration rates can vary between somewhere around 5% to up to 60%, depending on who you read. Those are the babies that generate the most controversy among surgeons. The 2-year-old in the office that comes in with a hernia that's easily reducible, I can tell you that the number of times I've seen a patient come back between the time you see them and the time you schedule them with an incarcerated hernia or a strangulated hernia is infrequent. Literally maybe once in my career of practicing surgery after fellowship. So it's mostly the premature infants that are the concerning patients. Generally speaking, in my practice, when I see an infant that has an inguinal hernia, a premature infant or an infant, I try to do the operation or schedule it within 2 to 4 weeks of seeing them in the office. Because if you're going to have an incarceration episode, it usually is within that. If you wait for longer than 4 weeks, I think you're running the risk of a higher risk of incarceration.
Now, Casey, when you're evaluating a child with let's call it a groin mass, is the differential difficult? Are they always a hernia? Can they be something else? There happens to be a question showing a pretty angry-looking groin in CSAP 17 in a child, and the question is, what's going on? Is this difficult?
It can be, especially for the general surgeon who's not accustomed to seeing children. But if you have an inguinal mass that is tender, red, and you take so if you take a history, for instance, and the parent relates that there's been a mass there that has come and gone, and now there's a mass there that hasn't gone, and it's red and angry, I think you have to have a very high level of suspicion that that's an incarcerated inguinal hernia. Of course, you can have, lymphadenitis or other etiologies, but the most important thing to rule out, so to speak, is an incarcerated inguinal hernia, because that carries the highest morbidity, and if you don't recognize that expeditiously.
And diagnostic assistance here, is this a place for ultrasound? Can that help you?
Yeah, great question. I think it really, like ultrasound anywhere, it really depends on who is doing the ultrasound and their expertise. But yes, if you have an experienced ultrasonographer or a radiologist, then you can certainly see evidence of bowel within a hernia sac in that particular instance. But it really is very dependent on where you practice. And for the general surgeon who's in private practice in an institution that probably doesn't have pediatric expertise, that can be challenging. So I think you just have to have a very high level of suspicion, and you've got a couple of options if you're a general surgeon. One, to send them to a pediatric institution, or 2, to explore the growing, or 3, to do diagnostic laparoscopy to determine whether or not this is an incarcerated hernia or not. I think the safest answer, if you were taking your oral board examination, is to explore the growing, because you can determine a lot just by doing that.
Now, you mentioned the technique, and you also mentioned laparoscopy. So is laparoscopy being used more and more to fix inguinal hernias in children?
Yes. I think since CSAP 16, I would venture to guess that a lot of young trained pediatric surgeons have adopted the laparoscopic technique. I myself still do the operation in the old-fashioned way, open through a small growing incision. And those who have expertise with the laparoscopic technique, I think, have demonstrated reasonably adequate results. But they're no better, I don't think, than the open operation, which is a tried-and-true operation that's been around for decades. The only real benefit in my mind is really a potential for improved cosmesis, which is, quite frankly, quite minimal. The only benefit really is that if you have a patient with a unilateral inguinal hernia, and say they're a year of age, there's approximately a 10 to 15% chance that they'll also have a contralateral patent processus vaginalis. And in those circumstances, if you do the operation laparoscopically, it's easy to identify that patient and fix the contralateral side under the same anesthetic. So the people that advocate for doing it laparoscopically use that as a piece of evidence to support their practice. Nevertheless, both of the operations in experienced hands, I think today, are probably adequate ways to close the patent processus vaginalis.
Okay, now we're going to be talking about some other surgical problems which are going to require general anesthesia. And there's something in the literature about the risk of cognitive decline in multiple anesthesias in children. Is that still a concern in the pediatric surgery world?
Yeah, it's definitely a concern, and there's been a lot written in the literature and by a number of organizations regarding those concerns, all of which are not very well substantiated to date. But parents ask a lot about this, and for good reason, because there's been a lot of stuff written about it in the lay press. And what I tell families is if there's a surgical condition that needs to be treated, then it should be treated, and those concerns of anesthesia are salient, but the condition to be treated is obviously more important. The one thing that is really key is that a small child be treated by an anesthesiologist experienced with administering anesthesia in small children. And I think there is some evidence to suggest that the anesthesiologist really is the most important part of the equation. Repetitive anesthetics are usually delivered for children that have life-threatening problems such as congenital heart disease, and there's really not a whole lot of choice to deliver anesthetics in those patients. But the common example for our practice on a day-to-day basis is the treatment of umbilical hernia, which we have now generally tried to delay until the ages of 3, 4, and sometimes 5 years of age to try to ameliorate the potential risk of early anesthetic exposure in the young toddler. But otherwise, I think you have to have an honest discussion with families about the potential risks of anesthesia, which clearly today are not very well known, although there's a lot of concern, and take it on a case-by-case basis of whether or not surgery is really necessary or not.
A caution and a warning, but not always well identified as what the real risk is.
Right. And general surgeons, if they want to read about this, probably the place to go is Smart Tots, which is a consensus statement that was endorsed by the FDA and a number of other organizations. And if you read the Smart Tots consensus statement, it really is about as vague as what I just stated. So I think you just have to be cautious about whether or not an operation is really necessary, and if so, then to highly consider employing the services of an anesthesiologist that's experienced with delivering anesthesia for children.
Let's change the topic, but stay on hernia. And is umbilical hernia a different story in the child?
Yeah, it definitely is. So for a couple of reasons. All of us are born with an umbilical hernia to some degree. There's an opening through which the umbilical cord passes that eventually closes, but in about 85% of people it doesn't close right away, meaning within the first couple of weeks of life. But it will, over the course of time, close. And so different than an inguinal hernia, which is a patency of an opening that failed to close, the umbilical hernia is a natural opening that will close over time if you be patient in many cases. Having said that, there are patients who present to our office at the age of 3, 4, or 5 that have an umbilical hernia that has not closed, and those are patients that we would consider for repair. The other caveat to umbilical hernia that's different than inguinal hernia is the risk of incarceration of an intra-abdominal organ, meaning a piece of intestine, is much lower in the setting of an umbilical hernia. And so we don't worry about incarceration so much with umbilical hernia compared to inguinal hernia. And so that's why most of us that practice pediatric surgery, and general surgery for that matter, ought to take a watch and wait approach for most patients with an umbilical hernia.
You clearly indicated that the inguinal hernia repair is ligation of the hernial sac, and obviously mesh is not used. What about umbilical hernias? Is mesh used when you close a umbilical hernia in children?
No, not in general. That umbilical hernia is the most common operation I do in my practice, and I'm venturing to guess it's probably similar to most pediatric surgeons that do general pediatric surgery. I have not used a piece of mesh to repair an umbilical hernia in 15 years. So the vast majority can be closed primarily with, I use a running suture technique. Most of us were trained to use interrupted sutures, but you can usually get the two leaflets of the musculature together transversely with the primary repair.
Well, before we leave the groin, we got a question in CSAP 17 on retractile testes. What are we really talking about when somebody mentions that after an exam of infant?
Right, so retractile testes are caused by a normal reflex, the so-called cremastoteric reflex, which are fibers that most people remember this or originate from the internal abdominal oblique musculature and surround the spermatic cord. Retractile testes are caused by that musculature contracting, usually in response to touching that area or cold temperature, etc. And the testis, which normally resides in the scrotum, retracts back up into the distal inguinal canal, or even higher than that sometimes. But the difference between a retractile testis and an undescended testis is the retractile testis normally resides in the scrotum or can be brought down gently into the scrotum with manual maneuvers and stays there. The real area that's difficult sometimes is that you get the testis down into the scrotum and it immediately pops back up in the office, which is what's prone to happen in most young males who are scared of physicians. But so a careful history is really important. But the retractile testis is a testis that resides in the scrotum and retracts on occasion up into the inguinal canal, and that generally does not require surgery.
So from a management standpoint, a retractile testis doesn't really require us to do anything?
That's correct, if it's truly retractile. But the definition, again, just to be clear, is you must be able to get the testis into the scrotum in a normal position without tension. If you pull it down and it immediately pops back up or it resides outside of the scrotum, then that's an undescended testis, and that should require a specialist for evaluation and or surgery.
And the difficulty or the risk with the undescended testis is what?
There's a number of reasons why a pediatric urologist or pediatric surgeon would offer a orchidopexy, which is an operation to attach the testis into the scrotum in a normal location. If the testis is not descended in the normal location after 6 months of age, I typically consider that abnormal. Some people use a year. Somewhere between 6 and 12 months, the testis should reside normally in the scrotum. If it doesn't reside normally in the scrotum, there's a number of reasons to bring it down. One is trauma. The testis that resides outside of the scrotum is actually more prone to traumatic injury. It's kind of counterintuitive, but if you think about it, it makes sense. Two, there's some thought that the testis functions more normally in its scrotal location with regards to spermatogenesis, etc., and so that's another reason. The third reason is that patients with true undescended testis are at a slightly higher risk for developing testicular cancer in the future. Now, bringing the testis down into the scrotum doesn't change the risk, but it obviously makes self-examination or examination by an advanced practitioner more reliable. It's hard to examine a testis that's in the inguinal canal. However, a testis that resides in the scrotum is much easier to examine. And then the last reason to do it is cosmesis. Obviously, a testis that resides in the scrotum looks more normal, and for young males that are walking around a locker room, that's obviously important. So those are the four main reasons why we contemplate doing an orchidopexy in a patient that has a true undescended testis.
And when you have an undescended testis and the parents are questioning what the risk of testicular cancer is over the lifetime of their child, is there a number that's commonly used?
Yeah, I usually tell people it's 1.5 times the normal rate. I think that's another area where there's not a great amount of literature. I think it also somewhat depends on the location of the testis. That's probably not something that I can corroborate with evidence, but clearly the patient with intra-abdominal testis, those might be different patients than a patient with a testis that's in the distal inguinal canal. But I tell everybody that from what I know currently that the risk is higher. What the actual risk is not entirely clear to me. but that's another reason to bring the testis down into a normal location.
Okay, well, let's change parts of the body. Let me give you a scenario, I guess. I just think my 5-year-old swallowed a button battery. He looks and acts fine, and I think, gee whiz, it's just a small button battery. Is that okay, or what should I do?
Yeah, well, what I would tell you is get in your car and start driving to the emergency department. And the other thing I would tell you, and this is interesting, is if you have any honey laying around your house, is to start having your child eat it. There's a pretty advanced algorithm for button battery management that can be obtained from any poison control center now, but there's been a heightened awareness, obviously, from people about these types of ingestions, which are much, much more common now than they were many years ago. If you look at that algorithm, it talks about the size of the battery, and I don't think it's really, to be honest with you, worthwhile you trying to investigate the size, because that basically just wastes time. The most important thing really is to get to a place where you can evaluate where the battery is and then take the appropriate steps to remove it if necessary.
We've got a picture of a button battery stuck in the esophagus. Is that a different problem than if it goes all the way into the stomach?
Yes, yeah. So one of the few pediatric surgical emergencies that we have at our hospital is that very scenario. If a child presents with a battery in the esophagus, we consider that a surgical emergency. And our quality measure aim is to try to get them into the operating room within 30 minutes for rigid esophagoscopy and removal. If you look at the data from the poison control centers, it's pretty clear that those types of batteries, and it kind of depends on the type and whatnot, but any type of button battery can cause pretty significant mucosal injury within 2 hours of exposure to the mucosa. So we consider that an emergency, and I would advocate that everybody else does too. Okay.
And in the stomach, do those just pass without any difficulty, or?
Yeah, so that's a great question, and that's somewhat of a conundrum. I think if it's in the stomach, again, what we would advocate for our institution, since we have a good number of advanced gastroenterologists who are adept at removing these from the stomach, we would still advocate removal. I don't think it requires a 30-minute trip within 30-minute trip to the operating room. But if it's clearly within the stomach, it's rational to consider removing it. Now, if you don't have that capability, if you're in a rural area and you can't get the patient to an advanced center to have that done, I think it also is responsible to observe the patient. But you need to be fastidious about ensuring that it passes through the GI tract. And how do you do that? Obviously, serial radiographs are probably the easiest way. There's some discussion about the size of the battery. The smaller batteries that are less than 12 millimeters in size probably act a little bit differently, but the 12 millimeter in size batteries are pretty rare. Most of the batteries that children are ingesting are the larger batteries. And just to give you a sense of size, because I had to look this up many years ago, a penny is 19 millimeters. So most of the batteries that we see that children ingest are greater than the diameter of the size of a penny. That's why if you're going back to that scenario of your 5-year-old, I'd tell you to seek medical attention right away.
Now, let's change this a little bit, and I think he's got one of those toys with magnets, or else he climbed up and grabbed some off my refrigerator, and he swallowed a couple of those. Is that different? Is that a problem?
Yeah, so I don't think it requires the same amount of urgency, but the issue with magnets is there's a couple of things. One is if it's stuck in the esophagus, then it probably ought to be removed, especially if he's symptomatic. So the common symptoms that children experience with esophageal and foreign bodies are generally drooling, sometimes some respiratory difficulty, feeding intolerance, etc. So if they're stuck in the esophagus, that makes the answer pretty easy. They ought to be removed. The conundrum comes when your child has swallowed more than one magnet that are not stuck to each other. And then the issue is what to do about that. And we certainly have seen patients over the course of the years who have swallowed magnets at different stages, and then they course through the GI tract at differing times. And during their course through the small intestine, meet each other between serosal surfaces. And so the patient that has a couple of magnets that are stuck to each other and they're in the stomach, I would treat that like I would any other foreign body that's past the lower esophageal sphincter other than a battery, and I would just let that pass. But if they're not joined, then that scenario is a little bit different. So if they're in the stomach and not joined, then I would try to go after those endoscopically. If they're at differing times through the course of the small intestine, I would just be very, very frank with the family about the fact that that child needs to return if there's any issues with abdominal pain or anything out of the ordinary from a symptomatology standpoint.
Sounds like a rational approach, so. All right, let's change the topic to another common topic that general surgeons face all the time, whether it's an adult or a child, and at least in the adult world, the treatment for appendicitis seems to be, to use your word, a conundrum sometimes, I guess. So this use of antibiotics for appendicitis, is that being applied to the pediatric patient?
Yes, it is.
And your thoughts on that?
I don't know if you want my thoughts.
Yes, we do.
I'll tell you what my current practice is based on what there is available currently in the pediatric literature. And there has been some interest in applying the same practice in adults to children, based currently on a couple of very small institutional case reports that have treated a select group of patients, and I emphasize select group of patients with early appendicitis that's clearly not perforated with antibiotics alone. And as it turns out, we just finished, our institution and a number of others finished a parent choice trial for patients to try to look at this at a broader scale. But nevertheless, it is being applied. We at our institution offer non-operative management for patients that met the criteria for the trial that just ended. And those criteria are a patient that shows up with less than 48 hours of symptoms. They have an ultrasound examination, which is our go-to radiographic assessment for appendicitis when the diagnosis is in question. And on that ultrasound examination, there cannot be a fecalith. And the appendiceal diameter has to be less than 8 millimeters. And the white count has to be less than 18,000. And so in those patients, we will offer non-operative management with antibiotic therapy. And the way we do that is we bring them in the hospital. We start them on our antibiotic du jour, which happens to be piperacillin tazobactam, and then reevaluate their response within 24 hours. If they are symptomatically improved, then we send them home on a short course of oral antibiotics.
How long is the course?
We have used 7 days. Okay.
And the number of antibiotics, because I know in the literature the pediatric patients seem to get more than one antibiotic when appendicitis is treated surgically. Is that also true?
Yeah, that was a great question, and I think that's very institutional dependent. I can tell you our experience has been to use single antibiotic therapy without using the trade name, piperacillin and tazobactam. It starts with a Z. So we use one agent. When we send them home on oral antibiotics, we do so with a single agent, amoxicillin clavulanate, which also has a trade name.
Well, the antibiotic stewardship community would be extremely proud of you guys.
Good. I can tell you where I trained, we used to use dual agent therapy, and I think there's still a number of people that do that. But we've looked at this through our own experience, and we do around 350 to 400 appendectomies a year. That we have found that that agent is totally adequate based on the bacteriology and our recidivism rate and postoperative abscess rate, etc. So we have not changed that practice for a number of years.
And the final question I'd like your opinion on in this area and is a common phenomena in our surgical literature. Somebody always has to compare the outcomes between general surgeons and pediatric surgeons with the disease process that both tend to treat depending upon the environment they live in. And there are a couple of reports of this happening for appendicitis showing that there may be a different approach for the two groups of surgeons. Comments? How do you feel?
Yeah. In our metropolitan area, I know that there are some groups of surgeons in private practice who definitely care for children with appendicitis, and I can tell you my anecdotal experience has been largely favorable. I know that there is literature out there that purports that there might be a difference. I think it really comes back to your comfort level as a general surgeon and whether or not your anesthesiologists are comfortable with providing anesthetic care to small children. You know, for the 16-year-old with appendicitis, I'll be honest with you, John, I don't think it really matters. For the 3-year-old, it may, mainly because of the anesthetic issues and the fact that many general surgeons are, quite frankly, not accustomed to operating in small children. The operation is pretty much the same. Obviously, you're not probably as comfortable with minimally invasive techniques if you're an adult surgeon for a 3-year-old, but to do the operation through a small right lower quadrant incision is, quite frankly, very acceptable. The other issue that's a common area of controversy is the child with perforated appendicitis and how you treat that. And there might be some differences in how that is treated between adult and pediatric centers, but that really is quite variable. So at the end of the day, I think if you're an adult surgeon and you're comfortable taking care of children, the operation is the same. You should go ahead and do it, just like you would in a 30-year-old. Again, if they're small children and you're not comfortable with the operation in a 2 or 3-year-old, then I think that's time to consider calling your pediatric colleagues for assistance.
Actually, we go back to I wouldn't call it minor, but the difference in anesthesia support and probably team support for the infant or the smaller child in a adult hospital primarily versus the pediatric hospital. Is that a fair comment?
I think so, yeah. I mean, and there's all the other bells and whistles that go along with a freestanding children's hospital that makes kids and parents feel good. I don't know if that has any difference in terms of outcome of treatment of appendicitis, but the fish tank in front of the hospital and all the child life things that go along with caring for children certainly are, I think, patient satisfiers. But at the end of the day, I don't think it probably changes the outcome for the treatment of the disease itself.
Okay, now let's talk about another common problem, at least I think it's the 2-year-old we usually see it in, and that is intussusception. Is this still treated non-operatively most commonly?
Most commonly, yes. Yeah. The 2-year-old is most likely to have what we probably problematically term idiopathic intussusception, meaning that they don't have a specific pathologic lead point. So the standard 2-year-old typically has a pre-existent viral illness, and that causes hypertrophy of the lymphoid aggregates at the distal end of the ileum, the so-called Peyer's patches, and those cause intussusception of the thickened ileum into the cecum and sometimes all the way to the end of the colon and out the anus, which is uncommon, but I've seen that before. So those patients, generally speaking, so long as they don't have symptoms of peritonitis that would prompt an immediate laparotomy or laparoscopy, those patients can, generally speaking, be treated with radiographic reduction. And for the most part, that's done with pneumatic air reduction today.
Is this still done with a contrast barium enema, or is another approach being used? Yeah,
so the contrast is air. In most pediatric centers, the air is the most, I think, commonly used contrast material. There's still some people out there that I'm sure use a barium column, but I think in most pediatric centers, air is now taken over as the leading way to reduce these, and air is a contrast medium that an experienced pediatric radiologist can use, and even an experienced radiologist in general.
And I read these articles about how to do this, and we talk about it in committee at CSAP 17. You know, nobody ever mentions failure rates, or is this always 100% successful?
Yeah, no, it's not 100% successful. The literature that I've read, and again, you have to take this with a grain of salt because not all the patients are the same, but I usually tell parents that about 9 out of 10 patients will get relief, or the air reduction will be successful. Again, in the absence of hard indications to go to the operating room. So it's highly successful, but there definitely are failures. The other thing that you may be ready to ask me about is what about the patient that, and this is common, what about the patient where the radiologist says they almost get it all the way reduced, but not quite? And then there's 2 pathways you can go down. Either A, go to the operating room and finish the job yourself as a surgeon, or B, take another shot at it after an hour or 2 of observation. And pathway B is actually quite frequently practiced and has been successful in my own anecdotal experience and that of others. So just because you don't get it all the way reduced the first time, so long as the patient remains stable and there's no hard reasons to go to the operating room, it is probably worth another try so long as the radiologist is comfortable in doing so. And you can save the patient a trip to the operating room. I think most parents would be in favor of that.
Okay. I was going to ask that. All right, so we got that covered.
The other common issue, if you're a general surgeon out in the community and there's a radiologist doing this, is they might ask you to be present at the bedside because of the potential risk for perforation. And that risk is small, but if you're using an air column or a pneumatic reduction and they get up to 100 millimeters of mercury and you create a hole, that can obviously be hemodynamically problematic. You basically have a tension pneumoperitoneum. And so that's why some radiologists still today will ask a surgeon to be present at the bedside. And all you really need is a big old angiocath in your pocket. And if that were to happen, you would place that angiocath just above the umbilicus, directed cranially, and decompress the abdomen. And now you can take your time getting to the operating room.
One more area of concern, because once again, the way most of us learn about this is we have the typical infant, the right age, the right presentation, and you kind of mentioned that 16-year-old for the appendicitis. Let's talk about a 16-year-old with intussusception. Managed the same way?
Great question. If they have what I would consider to be the classic intussusception, so ileocolic intussusception, and they are largely, they're not asymptomatic, that's why you're seeing them, but if they don't have any hard signs to go to the operating room, then I think an attempt at pneumatic reduction is certainly reasonable. But you have to understand that the pathogenesis of the problem may be entirely different, meaning that instead of having those hypertrophied pyrus patches, they have another reason why they've had this occur. And those are usually, there's a myriad list of what those can be. The most common things being a Meckel's diverticulum, other pathologic lead points, but that's by far and away the most common. So if you attempt a pneumatic air reduction and you're successful, what I would then do to that patient is tell them that the risk of having a pathologic lead point in somebody over the age of 5 is around 30%. It's not 100, but it's different than a patient that's less than 5 where it's around 2 to 3%. So then the question becomes, how do you work that up? And what's the most appropriate testing? Obviously, if they're not successful with pneumatic air reduction, that makes it easy. You go to the operating room, and then you can find out operatively. But if they are successful, then what I have generally done in my own practice is to obtain axial imaging, so a CT scan. And most of the time when I've been confronted with this scenario, I've been able to identify some type of lead point that I can then plan to take care of operatively after counseling the parent and the 16-year-old. So the other things you have to be wary of are other, pre-existing conditions. I think you want to ask me some questions later about cystic fibrosis. We can talk about that, I'm sure, later, but other pre-existing conditions that may lead to intussusception are patients with poorly treated cystic fibrosis, patients with lymphoma sometimes will present this way due to Burkitt's lymphoma, which can affect the mesentery of the distal ileum, and that acts as a lead point. So there's a whole host of other things you have to be concerned about in a 16-year-old.
Let's take another topic, and that's trauma resuscitation, or resuscitation after injury, let's call it. And
I think I should be asking you these questions.
No fair, Casey. Anyway, in the general surgery communities, there's been a couple of questions about this idea of balanced resuscitation that is taken off in the adult world, where we try to use minimal amounts of crystalloid and a balanced ratio of blood components. And the last series of questions was, well, does this apply to pediatric patients as well? And so I guess I'd ask you, is the resuscitation algorithm for children, and let's talk about blunt abdominal trauma, has it changed?
I can tell you what we do at our own institution, and we are a verified Level 1 pediatric trauma center, and we have followed suit with other pediatric Level 1 trauma centers, and because most of the stuff that we do really follows the adult experience. As you all in adult trauma surgery have done a tremendous amount of research in this area. So I think I can speak for our own institution, but I know this happens elsewhere, as we have followed that same algorithmic approach or change to how we resuscitate patients with blunt abdominal trauma. In general, we follow the guideline as if you've had 2 boluses of 20 cc's of isotonic fluid, and then we need to start thinking about activating a massive transfusion protocol and balancing or following the 1-to-1-to-1 recommendations that I think are widespread amongst adult centers. So yes, is the answer to your question. We've adopted that practice.
Doesn't this go against everything that's in the pediatric literature about the restriction of blood products? When I go back and look at management of splenic injuries, you guys started non-operative management of those.
Right. Well, that's a different story, I think. So for the patient with this isolated spleen injury whose hemodynamics do not prompt an immediate operation, we are very judicious about utilizing blood products because most of our patients are young and healthy and have healthy hearts and can tolerate a hemoglobin of 6, 7, 8. So we are, I think, more judicious about utilizing or not utilizing blood products in children. But I think your question was really related to the patient with massive ongoing hemorrhage, and those are patients that generally are going to end up in the operating room. But for the patient with a spleen injury, who you're not taking to the operating room and going to manage non-operatively, yeah, we are very conservative about using blood products.
Great contrast, and I think we sometimes forget that when something new appears on the horizon, we think it applies to everybody, but in reality, that we forget that the balanced resuscitation really is for that massively transfused individual, and your contrast is great, Casey. So it's a good thing to remember.
I can tell you in my experience here, and as you know, we take patients up to the age of 18 in our center. The vast majority of people that we're activating that balanced transfusion or massive transfusion protocol in are ending up in the operating room. It's a different subset of patients. So.
Let me ask another question about splenic injuries. The one that fails your non-operative management, and I know it doesn't happen very often, but is splenic salvage still in the back pocket of pediatric surgery for their injured patients with a splenic injury?
Yeah, I think it still is. As you know, I don't know if the data is all that great in terms of splenic function after an attempt at splenic salvage, but I think it really depends on the scenario. If you have a lower pole of the spleen that has a massive injury and there's an arterial bleeding source and you can control it, but the upper pole of the spleen looks pretty good, and you have a patient that's fairly stable in the operating room, then that might be a patient where you would consider taking out that lower part of the spleen and leaving them with their upper part of the spleen. As you know, that's not horribly common. Most of the time when we're taking out a spleen, it's because somebody is really in extremis. So it really kind of depends on the situation. We have had some patients in our institution, and I know others have had experience with this, in the older patients for splenic embolization. And I think that's a reasonable approach if you have people with expertise in that area. But the real issue is, and the thing that's a question to me is nobody's really looked at this very well, is what's splenic function after those types of operations. But I think it's worth an effort if you can do it and it doesn't jeopardize the safety of the patient.
There's an organ called the pancreas that lives close to the spleen. And I keep reading about these attempts to manage main duct injury that would normally be very amenable to a distal pancreatectomy, with or without a splenectomy. Let's leave that off the table for now. And people are talking about stenting these, and most of them seem to appear in children. Is this something that's common within the pediatric surgical world?
I would say from my reading of the literature and going to national meetings, the answer to that question is yes. I'm probably going to deviate from that practice, though, because I still believe that surgery is a very good option for the right patient. The patient you described with the distal ductal injury, who would be amenable to a distal pancreatectomy, who shows up in the emergency department, within at least 12 hours after their injury, I personally would still consider operating on that patient. I think the morbidity of leaving that alone, and the stent problems and the potential for a pseudocyst, et cetera, are really quite significant. And personally, in my hands, if the patient is quite stable from a hemodynamic standpoint, or at least normal, then that would be a patient that I would consider at least trying the operation laparoscopically, and I've certainly done that. But those are patients that I would still highly consider good candidates for an operation, and trying to preserve the spleen, as you alluded to earlier, which can safely be done in the majority of cases. So
sometimes trying to get too, I don't know if it's exotic or too specialized in treating a relatively simple injury that can be managed with a surgical procedure gets in the way of common sense.
Right. Yeah, we're surgeons. I mean, and that's everybody always jokes about the fact that, one of the rules of training is not to touch the pancreas, but I don't agree with that. The pancreas is an organ just like any other. It should be dealt with delicately, but in this particular scenario where there's a clear ductal injury to the left of the SMA, those would be patients that I would highly consider for operative therapy. The real question is, how do you make the diagnosis of the ductal injury? And sometimes that can be hard, when there's a bunch, especially for patients that show up later. They were seen at someplace else, and they come and it's been 36 hours, and now they have a bunch of epigastric pain, and now you discover that they have a pancreatic tail that just looks like a bomb exploded, and is that indicative of a ductal injury or not? And so we have used MRCP on a couple occasions for those patients to try to determine that, because as you know, that's the patient where operative intervention is fraught with difficulty, and the morbidity from those operations are high. So that would be a patient where I might take a little bit more expeditious and cautious approach prior to diving in their abdomen operatively.
Well, let me stay on trauma for a while, and unfortunately, we have experienced in the United States a number of mass casualty situations which involve penetrating wounds. And I guess I would ask you to comment on the fact that the adult world, some penetrating wounds with hemodynamic stability, are now thinking about being managed non-operatively. What about penetrating wounds to the abdomen in children? A gunshot wound with minimal abdominal findings. Comments?
Yeah, great question. And I know there's been some, like I said before, there's the pediatric world, I think, kind of follows the adult world in some of these practices, and there has been some, I think, interest in this strategy amongst some centers throughout our country. I can tell you here, we haven't caught on to that just yet. My own personal practice is to, take every patient individually, and if I still am an advocate for if they have violation of the peritoneum, especially a gunshot wound, I don't feel comfortable putting that patient on the floor and putting them on a monitor overnight. I would still advocate for, in that particular patient, I would actually do laparoscopy, and that has changed since I was in training. And where I trained in Denver, we would at that time we would just take that patient to the operating room and do a laparotomy. And the as you know from being a trauma surgeon, that's not always productive. You sometimes look in there and don't find anything. Now they have a big abdominal incision. But now with the advent of laparoscopic techniques, it's not a huge deal to take that patient to the operating room and do a thorough examination of their abdomen with the laparoscope, and you've now saved them that large laparotomy incision. So for me, I think I would still take a very cautious approach to anybody that wanted to observe a patient with a gunshot wound to the abdomen. Now, in that scenario where you have 30 patients, and you've got to triage those patients, that might be a patient that I wait on taking to the operating room for other patients that are more severely injured. But at the end of the day, I would still feel more appropriate if that patient were in isolation in my ER, taking him to the operating room and having a look. The other issue is CT scan. Do you do a CT scan for those patients as well? And I worry about the potential for a missed bowel injury, especially that soon after that incident. And so I would still feel more comfortable going to the operating room.
The imaging seems to be popular in some centers, and I would have to line up right behind you and say that most of those patients probably, whether you use laparoscopy and the patient who is really looks rock stable or do the lap, you're probably going to win most of those battles.
Yeah, agreed.
Well, let's stay in the abdomen, but let's talk about another problem that I'm sure you see, and that as well as adult surgeons see, and that's Crohn's colitis, or Crohn's disease, let's call it. Let's not specify one way or the other. But in the pediatric world, are the immunomodulators useful, or are they got too many side effects to be used in let's say a 12-year-old?
It's a great question, and this is one I had to actually read up on a little bit about because our gastroenterologists are so good that they manage most of these things. I will tell you that this landscape seems to change yearly with the advent of new agents. But the short answer to your question is yes, immunomodulators are used in young teenage people. I don't know if the side effect profiles are horribly different compared to a 40-year-old. I don't know if they've been used long enough to really understand if there's a significant difference in side effect profile between a 12-year-old and a 22-year-old. But they are commonly used by our own gastroenterologists, and I know other gastroenterologists around the country and the world. So it's a pretty common therapy for young people, depending on the nature of their Crohn's disease, of course. But yeah, I would say the vast majority of patients that come to our attention as pediatric surgeons have usually been on one, if not several, different types of immunomodulator agents.
Let's talk about some congenital problems, or some terms that are used, I think, associated with congenital issues that you probably see much more common than most general surgeons. But what's the latest on pyloric stenosis?
Well, the good news about pyloric stenosis is the treatment hasn't really changed very much in the last 100 years.
Well, that's good for most of us.
I always tell parents that this is one of the most gratifying conditions in pediatric surgery. It's a reversible condition ameliorated very nicely by an operation where you split the pyloric musculature, and the vast majority of children never have any adverse sequelae as a result of the condition or the operation. And by vast, I mean 99.99%. It's a very, very gratifying condition and an operation to perform. The thing that probably has changed in the last 20, 30 years is the fact that most pediatric surgeons today are doing the operation laparoscopically. And again, I think the benefit there is mostly cosmetic. But the cosmetic benefit actually is pretty significant. If you do the operation the way Ramstedt described it a long time ago through a right upper quadrant transverse incision, and you split the musculature of the rectus, those patients can have some pretty unsightly scars when they get to be older. I usually refer parents to Will Ferrell, who most people know who Will Ferrell is, a famous movie star, and he's got a pretty ugly looking scar on his upper abdomen. I'm a venture to guess he probably had pyloric stenosis when he was an infant, or if he didn't, that's what it can look like if it doesn't heal the right way. So that's how the condition is treated, and there hasn't been a whole lot of change in terms of how it's managed. There's been some interest in some medical therapy for patients who have refractory pyloric stenosis, and by that I mean atropine, but there's not a whole lot of experience with that in this country, and so surgical treatment is still the mainstay of therapy.
So let me push that a little bit and ask, do you think that a drug, or obviously Botox would come to mind, do you think that's ever going to come to pass as a treatment?
Well, I don't know if Botox will per se, because I don't think that probably really gets at the problem. But atropine is, like I said, not so much in this country, but I know there's been some studies in the Far East that have looked at this. And the success rates are not zero. I mean, they report success rates in the 70% range. So, yeah, there is some, I think there's some concern from the surgical side of me that that might be a therapy that someday is proven to be at least as effective, at least maybe as a first-line treatment for pyloric stenosis compared to surgery. Hope that doesn't come to pass from a purely personal perspective, but it's certainly intriguing. Just the data that's out there currently is not, I don't think, adequate to change what we currently have, which is a pretty good operation with a low mortality and morbidity rate.
And from a perioperative standpoint, obviously this is, for a medical student, this is almost I would say the example of a hypokalemic, hypochloremic metabolic alkalosis. And that still needs to be corrected before you take the child to the operating room for this definitive procedure? Yeah,
absolutely. And I tell our medical students, if they learn one thing and one thing only on their pediatric surgical rotation, and that is to say that pyloric stenosis is not a surgical emergency. It's a medical emergency to be certain, because those patients can have pretty adverse sequelae sometimes of gastric outlet obstruction, and you already delineated the electrolyte abnormality that we see. But we see 2 or 3 patients a year that end up in the ICU from this. I mean, this can be pretty catastrophic. The alkalosis can be severe and the dehydration profound. So there's absolutely zero reason to correct the hypertrophy of the pylorus until the patient is adequately resuscitated and the electrolyte disturbance has been corrected.
Okay. How about a duodenal web? And is a windsock deformity related to the presence of a duodenal web?
Yeah, so, webs can occur anywhere along the gastrointestinal tract. It's basically a luminal obstruction that's perforated. And those are pretty rare, to be honest with you. When they do come to attention in the duodenum, it's usually the child that, did well with formula and they've been growing normally, and then they start to introduce some solid food maybe, and they have more problems with vomiting, and so somebody ends up getting an upper GI, and lo and behold, the duodenum is distended, and they might have a trickle of contrast through that small perforated hole in the web. But that's an entirely different problem than pyloric stenosis, which is purely a hypertrophy of the muscle. The web problem is a congenital anomaly that, obviously, in that scenario that I just gave you, needs to be dealt with surgically. How you do it surgically may change in the future with the advent of endoscopic surgery, and I know there have been some groups that are very advanced with endoscopically resecting those webs or removing them without the need of a laparotomy or a laparoscopy. So that may change in the next 10 to 20 years, but currently the mainstay of therapy for any patient with luminal obstruction, whether it be a web or a stenosis or atresia, is still surgery, traditional surgery.
What about an annular pancreas? Is that something you see?
Yeah, we do. Typically, the annular pancreas itself is not the cause of obstruction, but they're typically associated with either stenosis of the duodenum or sometimes a web, as you mentioned. And so the patients that have obstruction as a result of either the annular pancreas or, like I said, usually the underlying duodenal problem generally do benefit from a consultation with an experienced pediatric surgeon and a discussion of how that can be ameliorated. You mentioned the windsock thing. The windsock is something that can make the operation difficult when you're talking about a web, and that is to say that the web might originate, say, in the first part of the duodenum, but if you look at the actual obstruction is downstream because the web has acted as a windsock, kind of like a windsock on a flagpole with the wind.
Like at the airport.
Yeah, exactly, like at the airport. And so to identify the origin of the windsock, you have to be cognizant of that surgically, and that's more of a technical issue. But where you make your duodenotomy is really dependent on where the origin of the windsock is, because if you make your duodenotomy well distal to where the origin is, it's going to be very hard to get up there and excise the origin of where the deformity is. And those are patients, though, that probably ought to be treated by a board-certified pediatric surgeon. Most of the other stuff we've talked about, I think a general surgeon can deal with, but that probably falls under the realm of asking somebody that's done the 2-year fellowship to get involved.
I just thought I'd throw in some of those congenital problems that we learn about a long time ago and then forget, so you can give us a quick review.
Right. The typical pyloric stenosis baby is a baby that's been otherwise healthy and then all of a sudden has the onset, usually progressive, of non-bilious emesis. I think we're going to talk about bilious emesis in a second, but it should always be non-bilious. If it's bilious, then that's a totally different story, and we're talking about other conditions that we may address here in a second.
And that leads me to the question, are we really worried about malrotations?
Yeah, you are. I mean, and that's the second thing I tell medical students if they learn anything on pediatric surgery, and that is the infant or the toddler, especially an infant, with green vomiting, that's an emergency. And that should prompt an immediate evaluation and a high degree of suspicion for volvulus, usually as a result of a rotational anomaly that most people term malrotation. But until you rule out that condition, you should not go to sleep. You should not rest. And you should not stop until you have assessed the baby and ruled out that as a possibility, because that is a life-threatening and potentially mortal problem if not dealt with expeditiously.
And the best way to rule that out is?
Still upper GI. Yep, a prompt upper GI.
So no fancy CT, just straightforward upper GI.
Right. It's a great question, though, because there are some centers that have gone to utilizing ultrasound, and what you'll see on ultrasound in a baby that has volvulus is the orientation of the SMA and SMV are reversed. Makes sense, right? But that's still not the gold standard. I think most people would still advocate for a upper GI for the patient. Again, this is the patient that doesn't need to immediately go to the operating room. There are patients that present with bilious vomiting who are in extremis and have an acute abdomen, and then what do you do as a surgeon? You operate. That shouldn't change. But the patient who has some green vomiting and looks pretty good, not an extremis, their belly might be a little distended, that's the patient you want to study, and the best, again, gold standard way to do that is an upper GI with contrast.
Now, is an NG tube necessary in those patients usually?
I would, maybe not right away, because you want to get that upper GI as soon as possible. But yeah, if you've got a patient that has volvulus, then once you've made the diagnosis, I would put an NG tube down on your way to the operating room. The other common scenario, since we're talking about general surgeons, is, what about the 6-month-old who's at a small rural hospital that has this? And this is probably one of those scenarios where a general surgeon can probably make a difference, even though he or she is not accustomed to treating infants and children. But if you've got an infant that's in extremis, then you should go to the operating room. And even if you don't know what you're doing, you can get out a book or get on the internet and figure out that the key thing is to open the abdomen and derotate the intestine into a normal anatomic position. And that's done by turning the bowel in an orientation to get the SMA and SMV open, typically a counterclockwise orientation. And if you can do that, you'll save the child's life, because if you try to put that child on an ambulance or a plane, that just delays the inevitable, and the clock is ticking on those patients. So it's the sort of thing that a general surgeon, especially if they're practicing in a rural setting, probably ought to spend some time thinking about what he or she would do in that scenario, because it probably will happen to that person in the course of their practice at least once.
Casey, let me just ask you, has there been any changes in the treatment of either omphalocele or gastroschisis from a pediatric surgery standpoint? I realize most general surgeons aren't going to be taking care of these, but are you guys doing anything different than you usually have done?
It's a great question, and yes, we are, actually, as it relates to gastroschisis. Not so much omphalocele. Omphalocele is a defect of the umbilicus where the intestinal contents are covered by an amniotic sac or amnion sac that emanates through the umbilical defect. Gastroschisis is a defect that is not covered by amnion, that occurs usually to the right of the umbilicus. I've never seen one occur to the left, even though it says that in textbooks, but it's usually always to the right. There's an intact umbilical cord. And gastroschisis, in the past, we would generally take those patients to the operating room and try to reduce the contents. And if we weren't able to reduce them, we would place a silo or a temporary housing over those contents, and over the course of the next several days reduce them. What has changed in the last several years, probably since CSAP 16, is that a lot of pediatric centers have gone to trying to do that reduction at the bedside in the NICU without the baby on the ventilator, which is dramatically different than how I was trained. So if you've got a baby, and most babies with gastroschisis come out and they look entirely normal. They're breathing normally. They don't generally have other congenital anomalies. Sometimes they're a little bit smaller for gestational age, but otherwise they're typically fairly healthy. And so that prompted some people years ago to say, well, why don't we try to do this at the bedside? And a lot of pediatric centers have since followed suit. So we basically, with the neonatologists along with us, they provide a little bit of sedation, monitoring of their oxygenation, saturation, et cetera, like an anesthesiologist would, without intubating the baby. And then we gently try to reduce those contents back into the abdominal cavity. And in our experience, we're successful in doing that about 2/3 of the time, which is pretty cool. We don't have to take patients to the operating room. And then instead of using sutures to close that hole, we use a remnant of the umbilical cord, which is generally by our obstetricians left very long because we know most of these patients are coming. And we use that kind of as an amniotic patch. We flop the umbilical cord over that defect just right next door, and we put a bunch of gauze and Tegaderm and wrap the baby in some non-inherent dressing, Curlex, etc., and we're done. So it's really changed how we treat those patients.
So no routine trips to the operating room and tightening down those silos, at least in gastroschisis.
Right. Well, and then there's a subset of babies, though, where you can't get it reduced. And so those are generally children that either, and at least in our algorithm, if we can't get it reduced at the bedside like that, then we take them to the operating room and either try to get it reduced with the baby under anesthesia, or more often than not, in those babies, we're putting a silo on. There's some centers that if they can't get it reduced at the bedside, they just put a silo on and then treat it like you would any baby with a gastroschisis that can't be primarily repaired. The cool thing about that, though, is if you see those patients back that have had a successful repair with that amnion patch from the umbilical cord, it looks beautiful, number one, cosmetically speaking. And number two, it's kind of like an umbilical hernia. A lot of those patients in my practice so far have had a muscular defect, obviously right away, but over time it closes. And so I've had a couple of patients where I thought for sure when we started doing this, we'd have to go back at some point and fix that little ventral hernia. And in fact, didn't have to do that. So it's a gratifying little procedure and has definitely changed the way we treat that condition for a subset of patients.
Well, Casey, it's been great talking to you this morning. Let me ask you, From your position as the accepting pediatric surgeon, are there any other issues that I forgot to ask you about that a general surgeon should know about to help him or her achieve a great outcome in the pediatric population they have to deal with?
You covered a lot of the very common questions that we get on call from surgeons that call in asking for advice. Being a trauma center, the majority of questions or the people that we're talking to at other institutions that are general surgeons are typically related to trauma. The very common questions that we get also are related to hernias, and I think we covered that very nicely. One of the other common things that we deal with not infrequently is chest issues, and specifically spontaneous pneumothorax, and what to do about that. I can tell the general surgeon that has a patient, and it's usually a thin young male who's otherwise healthy, who presents with shortness of breath, and the ER has gotten a chest x-ray, and there's a significant pneumothorax on one side, usually not both, but usually one side, and what to do about it. Obviously, if they are 4 hours away, that's not the patient that you want to put on a plane or a helicopter for obvious reasons. But for the most part, many patients who are minimally symptomatic can be treated at least initially with either non-operative management or aspiration of the air from the pleural space to allow for transport. What we generally have done here in patients that have a considerable pneumothorax is to put a small caliber chest tube in and rate the results of that treatment. But that's probably one thing in the general surgery world that you might face.
Good point. I forgot those. And most of those, do they require some kind of procedure to evaluate them for blebs, and then I suspect a VATS approach on those?
Yeah, the real number of what the recurrence rate is all over the map. I usually tell people that there's about a 50-50 shot after a single episode of non-operative or non-VATS type of procedures working and being durable over the course of a lifetime. The controversial area is what imaging you do and when you do it. Do you do imaging, or do you just take patients to the operating room right away? And that still is an unanswered question in pediatric surgery that causes a lot of discussion at meetings. But certainly after a single episode, I think it's reasonable to at least counsel families about the potential success rate of tube thoracostomy or even aspiration alone. The patients with other comorbid conditions like Marfan syndrome or Ehlers-Danlos, those are patients that are unlikely to have a long-term durable result, and I might have a different conversation with the family in those cases. But I generally don't get imaging routinely in the normal scenario where I describe where it's a 16-year-old otherwise healthy child. After a second episode, I generally just go to the operating room. A CT scan is not going to tell me something that I don't already know. They typically have bullae or bleb disease of the apex of their lungs that you can see at the time of thoracoscopy, and then I deal with it and try to absolve them from having to undergo a CT scan with the attendant radiation.
Again, the straightforward approach sometimes is the best.
Right. The real issue is what about the other side, and there's a lot of controversy. If you have blebs or bullae on one side, is there a chance that you'll have them on the other? And that risk is somewhere probably in the 10 to 20% range. I tend to again avoid doing something about a condition that's not symptomatic unless they're avid scuba divers or something like that, which thankfully is pretty rare up here in Milwaukee.
Well, again, I appreciate you spending time with me this morning, and I think you've given us a lot of great hints and given us a preview of what CSEP 17 looks like. So, again, thanks a lot, Casey.
My pleasure.
That's it for this category of the CSEP 17 Audio Companion.